Hello and welcome to this interview on Oncology Central with Ahmad Awada. Thank you for joining us today.
Thank you for the invitation.
Thank you. Could you briefly introduce yourself?
Yes, I am Ahmad Awada. I am the head of Oncology Medicine Department in Jules Bordet Institute in Brussels, Belgium. I started my career as medical oncologist in 1992 by doing a fellowship in the Netherlands in New Drug Development Office, and after that in San Antonio for in the setting of new drug development too. And so I came back to Brussels in 1994, and I started my career as medical oncologist with my main focus solid tumors, in particular breast cancer and new drugs development. So my main field, my main expertise is in new drug development, in particular in relation to breast cancer. So I participated to a lot of clinical trials from phase 1 to phase 3 trials in solid tumors, including breast cancer. So for the moment, I am the head of Oncology Medicine Department, which is responsible in charge all patients with solid tumor treated in our institution, which is a cancer center in Brussels, Belgium. Jules Bordet Institute is a cancer center, comprehensive cancer center, the only one in Belgium. There are many oncology departments, but Jules Bordet Institute is the only comprehensive cancer center.
Okay, so can you tell us about the current treatment options for triple-negative breast cancer?
Triple-negative breast cancer is approximately 10 to 15% of all breast cancer patients. This molecular group of breast cancer defined by the absence of PR expression as well HER2 expression. So we know this disease is very, very heterogeneous, genomically speaking. You know, we dissect the genomic landscape of triple-negative breast cancer, not yet completely understood, but we know is really, from the clinical point of view, this is a very, very complex disease, very heterogeneous disease. And we know why by doing the genomic analysis. So it's a very complex disease. And so for the moment, the chemotherapy is the backbone of any treatment for triple-negative breast cancer. Nearly the majority, extreme majority of these patients received neoadjuvant chemotherapy or adjuvant chemotherapy based on anthracycline, taxane, plus or minus carboplatin, according to the status, in particular BRCA mutation, yes or not. And more recently, for patients who receive neoadjuvant anthracycline taxane-based therapy and who develop, let's say, residual disease at the time of surgery, some of these patients receive now capecitabine as adjuvant therapy. So the extreme majority of our patients receive chemotherapy in the neoadjuvant setting because there are no other option in early setting. Part of these patients are cured by local approach, surgery, radiation, and neoadjuvant chemotherapy. But unfortunately, a group of these patients recur mainly in the first 3-4 years after the diagnosis of primary tumor. And so this patient now receive, let's say, adjuvant chemotherapy. But we know once the patient recur, in particular if the patient is a young patient, we know that the prognosis of this patient is very, very bad. So basically, chemotherapy remains the major therapeutic approach in the adjuvant setting as well in the metastatic setting. More recently, immunotherapy, at least one of the checkpoint inhibitors studied in the first-line setting of triple-negative breast cancer, showed interesting result. So for patients with triple-negative breast cancer, PD-L1 positive in immune cells, 1+ or more, so were randomized to Abraxane, is a taxane, in combination with atezolizumab, which is PD-L1 inhibitor, and compared to chemotherapy alone, and this trial showed improvement in survival. And this study will be, the survival data will be presented during ASCO 2019. So for this group of patients, which is around 40% of the triple-negative breast cancer population, we have now in the first-line setting this combination. In terms of other molecular subtyping of triple-negative breast cancer, there are one subgroup which express androgen receptor, but so far there are no room to prescribe anti-androgen therapy in this group of patients. AKT are also studied in combination with inhibitors. AKT inhibitors are studied also in combination with chemo in this setting. So hopefully we'll see in the near future some improvement in the management of metastatic disease. Finally, it's important to remember too that part of this patient, triple-negative breast cancer patient, had germline BRCA mutation. And so this patient could benefit from what's called PARP inhibitor, administered mainly a single agent in patients already pretreated with chemotherapeutic agent, and showed some benefit from PARP inhibitor. So basically, this is really the basis of triple-negative breast cancer therapy today.
Okay. Can you tell us about the mechanism of action of Eryaspase and why, in your opinion, Eryaspase is a good candidate for triple-negative breast cancer?
This is a really very important question because, as I mentioned earlier, I mentioned that triple-negative breast cancer is a very, very complex disease and heterogeneous at the clinical level as well as the molecular level. And so, of course, we can go with specific therapy, with targeted therapy, but probably this will not be the solution for, let's say, triple-negative breast cancer at the time of recurrence. And it's really we know from the preclinical setting that the metabolic pathway is also dysregulated in breast cancer as a whole, in particular in triple-negative breast cancer. And for all these molecular subtypes, one of the common pathway which is dysregulated is the metabolic pathway. So it's really important to look to therapeutic approach which targeting the metabolic pathway. And so Eryaspase is really a new approach, therapeutic approach, which really at least deal with one of part of the metabolic pathway. The Eryaspase is really built in such a way that this enzyme is put in red blood cell, which is by definition circulating, including in the tumor, and transform one of the really important amino acid important for the growth of the tumor, for the proliferation of the tumor, which is asparagine. And asparaginase transforms this amino acid to aspartic acid. And so the red blood cell was used as a vehicle, and particular to go in tumor. So, and to deal with this metabolic dysregulation, which is common pathway for all molecular groups inside the triple-negative breast cancer. So for all this reason, I think Eryaspase is, let's say, a rational approach, but we know by itself is not enough and should be combined with chemotherapy. And this is what's ongoing now in a clinical trial.
Okay. Could you let us know how the Tribeca-2 study is designed?
Yeah, I think it was designed in such form that not to go to phase 3 from the beginning. We'll go as first part to a phase 2 study, randomized phase 2 study, using a common combination chemotherapy in triple-negative breast cancer in patients already pretreated on anthracycline and taxane, as I mentioned earlier, in the adjuvant setting. This is a first-line study. The phase 2 part is a first-line study combining carboplatin and gemcitabine, which is a common combination chemotherapy used in triple-negative breast cancer, plus or minus Eryaspase. So approximately 64 patients will enter on this trial, and the main endpoint will be objective response rate. And of course, we look to other endpoints on this trial: progression-free survival, overall survival, disease control rate, and so on. And after this important, let's say, phase 2 randomized trial, we look to the result. And if the results are promising, and hopefully will be promising, we'll pursue to phase 3 trials, which will be adapted according to the result obtained in the phase 2 part. So Eryaspase will be studied in 2 parts, phase 2 and later on phase 3, based on the result we'll observe in the phase 2 part.
Okay, thank you very much. Could you let me know what talks you're looking forward to at ASCO this year?
I think we are looking to see the updated result from inpatient 130 trials. I mentioned earlier during this interview, which look to the efficacy of Abraxane plus atezolizumab compared to Abraxane alone in triple-negative breast cancer PD-L1 positive population. We'll have, to my knowledge, the final survival data. Already we know there are significant advantage on the survival data for the combination, so we'll have an update on that. We'll see, I think, Tuesday, the last day of this meeting, some new data on anti-HER2 therapy in patients pretreated with prior anti-HER2 therapy, and this is really of great importance for clinical practice. Basically, HER2 disease also is a smaller group of patients, around 15% of the patients, but there we have already chemotherapy and we have targeted therapy, and so more targeted therapy are coming here to advance more the management of this disease. I think we'll observe also with great attention a study called NALA trials, which compare also neratinib anti-HER2 therapy plus capecitabine, and compared to lapatinib, another anti-HER2 therapy plus capecitabine. And so this is also an important study. So I think, to my knowledge, this is 3 important studies will be presented during this meeting.
Okay, fantastic. I look forward to hearing them. Do you have anything else you would like to add?
I think it's really always important. I think targeted therapy is very nice to develop targeted therapy, to develop chemotherapeutic agent, but it's really important to develop, let's say, approaches which target common pathway for a group of breast cancer patients or the whole of breast cancer patient in order to advance fast in the management of this disease. This is a complex disease, heterogeneous disease. Of course, segmentation could help for a very small group of patients, but it's important. Breast cancer is a huge problem, as you know, and it's important to have, let's say, drugs or therapeutic approach which could target common pathway for the whole disease or for this group of the disease. I mean by that luminal disease, triple-negative breast cancer, or HER2 disease.
Okay. Well, thank you very much for joining us today.
You're welcome.